Welcome back to the Deep Dive. Today we are taking on, well, one of the most critical areas in all of anesthesiology.
Airway management.
Exactly. We're focusing on the tools of the trade laryngoscopes and, of course, video laryngoscopy.
And this is really for those of you deep in preparation for your MD anesthesiology exams.
Yes, whether you're facing a long answer theory question or you're standing at that dreaded Viva table, this stuff is absolutely foundational.
Right. And we're not just going to skim the surface.
No, we're diving into the clinical details, the mechanics, and those critical comparisons that, honestly, separate a good candidate from a great one.
Precisely. The goal here isn't just to have you recite facts. It's to give you a solid framework, a structure for a really comprehensive, high-scoring answer.
Because at the end of the day, airway visualization is everything.
It's non-negotiable for patient safety. So if you get a question on this, we want you to be able to talk about the whole story, the evolution, the application, and just as importantly, the limitations.
Okay, so let's set the stage. We all know the device is called a laryngoscope, but what's its full clinical role? It's so much more than just a tool to get an endotracheal tube in, isn't it?
Oh, absolutely. I mean, yes, its primary job in our world is to visualize the larynx and the vocal cords to help us with intubation.
The main event.
The main event. But you have to remember its wider utility. Laryngoscopes are crucial for just getting a detailed look at the anatomy of the larynx.
See, for diagnostics too.
Yes, exactly. Assessing things like vocal cord palsies, identifying lesions for a biopsy, or even just helping to guide something like a nasogastric tube when it's being difficult.
That's a great point.
And you should always remember the basic anatomy, for the exam. The larynx's main evolutionary job is protection. It's a valve, a very sophisticated one, to stop us from aspirating. Our tools are designed to, well, temporarily and safely bypass that valve.
So the whole story of the laryngoscope is really about overcoming one single challenge.
The line of sight.
The line of sight. It starts with direct vision, or DL, and this goes way, way back.
It does. Alfred Kirstein, 1895. But it wasn't the bedrock of modern anesthesia just yet.
No, that came later, with Sir Robert Macintosh and Sir Ivan Magill. They're the ones who really popularized the technique and that classic curved blade design back in the early 1940s.
And for decades, for nearly 60 years, the Macintosh blade was it. It was the unquestioned standard.
And that standard was always fighting against anatomy.
A constant battle. Direct laryngoscopy demands that your eye, the glottis, and the instrument all line up perfectly.
A straight line that patient anatomy just doesn't want to give you.
Exactly, which is what led to the next revolution, video laryngoscopy, or VL. It was a direct answer to that limitation.
So this is more recent.
Much more. The real shift started in the 2000s. A key figure was the Canadian surgeon John A. Pacey. In 2001, his big innovation was embedding a tiny camera chip into a modified Macintosh blade.
And that became the Glidescope.
That became the Glidescope, and it fundamentally changed the game. It introduced this idea of indirect visualization.
The ability to look around the corner.
That's the perfect way to put it. You're no longer fighting for that straight line of sight.
Knowing that history really helps frame where we are now. But let's bring it back to the exam perspective. What are the key connections our listeners need to master?
Okay, so you can't talk about laryngoscopy without talking about anatomy. It's just impossible. So be ready for Viva questions on the larynx itself, its innervation, especially the superior and recurrent laryngeal nerves, and the clinical signs of vocal cord palsies.
But the absolute centerpiece, the thing you have to know inside and out?
The modified Cormack-Lehane grading system. You have to understand it, not just memorize the grades. It's the universal language we use to communicate how difficult an airway is.
And for that long theory answer, that comparison between the classic Macintosh and the newer video laryngoscopes.
It's almost guaranteed to come up. You need a structured answer covering the mechanism, how they're used in difficult airways, the costs, the safety trade-offs. You need to nail that comparison.
A good answer always starts with a clear classification. So let's lay out how we organize all these different tools.
Perfect.
So if we're looking at the big picture, the highest level distinction is based on how you actually see the larynx, right? The technique itself.
That's it. And that immediately gives you two main categories. First, you have the direct laryngoscopes, the DLs.
The classics.
The classics. These use a rigid instrument to literally create a direct line of sight from your eye to the glottis. You're physically moving tissue out of the way to see.
Okay, and the second category?
The indirect laryngoscopes, or ILs, these let you see the glottis using some kind of optical aid. It could be fiber optic bundles, mirrors, prisms.
Or, most importantly for us today, video cameras.
Right. Video laryngoscopes, or VLs, fall squarely into this indirect category.
Okay, so within those traditional DL devices, the next level of classification is the blade itself, the physical design.
Correct. And that design really dictates how you use it. We split them into curved blades, with the Macintosh being the prime example.
A smooth, gentle curve from base to tip.
Exactly. And then you have the straight blades, like the Miller.
Yeah.
It has a straight spatula, and it's designed for a totally different, more direct lifting method.
So why do we need all these different types? What's the clinical relevance of having this whole arsenal of tools?
This is the so what question, and it's vital. The fundamental takeaway is that there is absolutely no single standard laryngoscope that works for every patient.
It's not one size fits all.
Not at all. The choice is always multifactorial. It depends on the reason you're doing it. Is it a routine case or a known difficult airway? It depends on the patient's anatomy. An adult is different from a child. Someone with a rigid neck presents a unique challenge.
And it also comes down to the person holding the scope.
Of course. The personal preference and the experience of the anesthesiologist are huge factors. You need to know the strengths and weaknesses of each type to make the best choice in the moment.
And then the newer VLs, they add even more layers to this classification.
They do. VLs are subclassified in two really important ways. First is by whether they have a tube channel.
So channeled versus non-channeled.
Right. Channel devices, like the Airtraq, have a built-in guide. You get the view, you push the tube, and the channel directs it. Non-channel devices, like the Glidescope or a CMAC, require you to use a separate stylet to guide the tube in.
And the second classification for VLs
is the angulation of the blade. Some blades mimic the standard Macintosh curve, but others are highly curved or hyperangulated, and that dramatically changes the technique you need to use. This variety is what lets us tailor the tool to the specific anatomical problem we're trying to solve.
With that roadmap laid out, let's really focus on the workhorse of airway management, the direct laryngoscopes. This is such high-yield material, we need to make sure everyone can describe the components and the mechanics perfectly.
Okay, let's assume our listeners know the basic parts. We should focus on the clinical relevance of each component. What makes it important in practice?
Good idea. Let's start with the handle. It's more than just something to hold on to.
Much more. The handle is your point of leverage. The surface is roughened for a reason, to give you good traction during that critical lifting part of the procedure. It's also where the batteries are housed.
And it's part of the electrical circuit.
Right. When you engage the blade and open it up, you complete a circuit, and that illuminates the light source. And you mentioned size before handle. Size matters.
A short handle can be a lifesaver.
It really can. Think of a patient with a very large chest or breasts, where a standard handle would literally hit them, preventing you from getting the right lifting angle. Or a situation where an assistant is applying cricoid pressure and you just don't have the space.
Okay, moving on to the blade. This is the part that goes into the mouth. We need to be able to name its parts for the exam.
And you need to understand them functionally. The main shaft is the spatula, or the tongue. Its job is to compress all that soft tissue to open up your line of sight.
Then there's the flange.
The flange is that vertical wall. It has two critical functions. First, it guides your endotracheal tube. Second, and this is key, it deflects the patient's tongue over to the left side of the mouth, clearing your view.
And finally, the tip.
The tip, or the beak. It's blunt to reduce trauma, and its exact placement is what defines the entire technique. Whether it goes into the vallecula or under the epiglottis, that's the whole ballgame.
Let's touch on the light source. The evolution from a little bulb to fiber optics is a big deal.
A huge deal. The old system had a bulb screwed right onto the blade near the tip. This was problematic.
A detached bulb is a foreign body risk.
A major risk. And those electrical contacts are a nightmare to sterilize properly. Fiber optics solved all of that. The bulb is now safely located in the handle, and the light is transmitted through a fiber optic bundle right to the tip.
So you get brighter, cooler light.
Brighter, cooler light, and because there are no electrical bits on the blade itself, sterilization is much, much easier and more effective. It's a massive improvement in safety and function.
Okay, let's get into the blades themselves. High-yield stuff. Let's start with the king, the Macintosh blade.
The Macintosh is the standard for adults. It's a curved blade, and it's designed for an indirect lift of the epiglottis.
You have to know the key features.
You do. The spatula and flange create that unique reverse Z shape in cross-section. The tip is blunt to minimize trauma. And you need to know the sizes. Size 3 is your standard medium adult. Size 4 is for larger patients.
And in the other corner, we have the Miller blade, the straight contrast.
The Miller is the classic straight blade. It's often preferred for infants and children.
Why is that?
Because in kids, the epiglottis is, well, it's floppier and it sits higher up, more cephalid, so it's often easier to just go under it and lift it directly. The Miller is also useful in adults who have a particularly long, floppy epiglottis.
And the common adult size.
A Miller size 2 is what you'll most commonly see used in adults.
Now, for the great innovation, designed specifically for difficult, direct laryngoscopy, the McCoy blade.
You absolutely have to be able to describe the McCoy in detail. It's a modified Macintosh, but it has a hinged, adjustable tip.
Controlled by a lever on the handle.
Exactly. So when you're struggling to get a good view, you activate the lever, and that flexes the tip. This elevates the epiglottis, but requires much less vertical lifting force from your arm.
And the innovation is brilliant.
It's twofold. First, as you said, less force overall. Second, and this is the crucial safety feature, flexing the tip actually moves the fulcrum point deeper into the pharynx,
Away from the teeth.
away from the upper incisors. This massively reduces the risk of accidentally levering on and damaging the patient's teeth. It's a game changer in a difficult intubation.
For a top-tier long answer, it's good to mention a few specialty blades to show the depths of your knowledge.
Definitely. Think about the anatomical challenges. What if you have a patient with severely restricted neck mobility or maybe kyphosis? The angle between the handle and the patient can make a standard lift impossible.
That's where something like the polio blade comes in.
Precisely. The polio blade offsets the blade from the handle at an obtuse angle. This allows your hand to clear a large chest or breasts.
But there's a trade-off.
A big one. You get less control, and you can't apply as much vertical lifting force safely.
And what about the opposite problem? Limited mouth opening.
For that, you'd think of the Bizarre-Guafrida blade. It's basically a Macintosh blade, but with the flange almost completely removed.
So it's thinner.
Much thinner, laterally. By minimizing the space needed for insertion, it's designed specifically for patients with a small mouth opening, maybe because of prominent incisors or a receding jaw.
Okay, let's move on to technique. The technique of direct laryngoscopy is a foundational skill, and it all starts with positioning.
Positioning is half the battle won before you even start. The goal is simple. You want to bring the oral, pharyngeal, and laryngeal axes into alignment.
And we achieve that with the sniffing position.
The famous sniffing position. It involves two distinct movements. First, you need flexion of the lower cervical spine. You get that by placing a small, firm pillow under the patient's head.
And then
you have extension of the head at the atlanto-occipital joint. The head looks like it's sniffing the morning air. That's the classic position.
is it different for neonates and children?
It is, and that's an important distinction. Because of their proportionately larger occiput, their head is already naturally flexed. So often all you need is simple head extension or maybe just a small roll under the shoulders to get the alignment right.
Okay, the patient is positioned. Now for insertion.
Key points for the exam. You always hold the laryngoscope in your left hand.
Always the left.
Always. You open the mouth with your right hand using the scissors technique, thumb on the lower molars, index or middle finger on the upper molars.
And where do you insert the blade?
You insert the blade from the right side of the mouth. You advance it along the side of the tongue, and the goal is to use the flange to sweep the entire bulk of the tongue over to the left, out of your way.
Now for the moment of truth. The lifting maneuver. This is where success or dental trauma happens.
This is a high-stakes point, both clinically and in an exam. The force must be applied along the axis of the handle. It's an upward and away motion, often described as a 45-degree angle.
And the cardinal rule.
The absolute cardinal rule, which you must state clearly, is that you never, ever use the upper teeth as a fulcrum.
This is the fulcrum error.
The fulcrum error. The force has to come from your wrist and your forearm, directed parallel to the handle. You are lifting, not levering. Avoiding this error is the primary safety measure in all of direct laryngoscopy.
That distinction brings us right back to the mechanism of glottic exposure. How do the Macintosh and Miller blades use different anatomical landmarks to get that view?
The curved Macintosh blade uses an indirect lift. This is key.
So you're not lifting the epiglottis itself.
Correct. You place the tip of the blade into the vallecula. That's the space between the base of the tongue and the front of the epiglottis.
Oh.
When you lift, you're actually lifting the base of the tongue. This puts tension on the Hyoepiglottic ligament, and it's that tension that indirectly pulls the epiglottis forward and up, exposing the glottis.
A very elegant mechanism.
It is.
And the straight Miller blade.
It's a completely different philosophy. It's a direct lift. The tip is advanced until it goes past or posterior to the epiglottis.
So you're going underneath it.
You are literally scooping under the epiglottis and lifting it directly forward. And this is why depth is so critical with a Miller.
Right, the trap warning.
Exactly. Go too deep, and you're in the esophagus. Don't go deep enough, and the epiglottis just flops back down and blocks your view. The sweet spot is just past the edge of the epiglottis, near the anterior commissure of the cords.
So if we were to summarize the pros and cons of DL before we get into complications.
Well, the advantages are clear. It's familiar, it's universally available, it's cheap, and it's reliable in routine airways. The Macintosh, in particular, with that wide flange, gives you a lot of room to pass the tube.
And it's generally safer for teeth.
The curved blades are generally considered less likely to cause dental damage. The big limitation, however, is its total dependence on getting that anatomical alignment right. If the patient has a short, stiff neck or can't open their mouth wide, you simply can't achieve the line of sight and your success rate plummets.
Which leads us to the inevitable. Complications of direct laryngoscopy. We've hit on dental trauma, but let's cover the full spectrum.
As we've stressed, dental trauma is the most common mechanical complication, and it almost always happens because of the fulcrum error.
Using the teeth as a lever.
Yes. You can also get soft tissue injury to the lips, the gums, the pharynx during insertion, and then there are the physiological responses.
It's a very stimulating procedure.
Very. It can cause profound vagal stimulation, which can lead to bradycardia. This is especially true in children. And of course, there's always the risk of laryngeal spasm.
Which is what? Exactly.
It's an exaggerated glottic closure reflex. It's triggered by irritation from the blade or secretions when the patient is at an inadequate depth of anesthesia. It's a true airway emergency.
This whole problem of not being able to see well leads us perfectly to the common language we use to grade the view. Laryngoscopic views and grading.
This system, from Cormack-Lehane back in 1984, is the absolute cornerstone of how we document and communicate airway difficulty. You must know it.
Let's start with the original 4 grades.
Okay, grade 1 is a perfect view. You can see the entire glottis, the full length of the vocal cords. Easy.
Grade 2?
Grade 3 is when you can only see the posterior part of the glottis. You can't see the anterior commissure.
And grade 3 is where it gets tough.
Very tough. Grade 3 means you can only see the epiglottis. The glottic opening itself is completely hidden from view.
And the worst case scenario.
Grade 3. You can't see any recognizable laryngeal structures at all, not even the epiglottis. You're flying blind.
But the modified Cormack-Lehane grading adds some crucial detail, especially to grade 2.
It does. This modification provides better, more reliable information. Grade 3 is still a full view, but grade 3 is split.
Into Aya and I-Bear.
Right. Grade 3, Guy, is when you can see the posterior part of the vocal cords. It's a partial view, but usually still an easy intubation.
Grade tube is the problem.
Grade IB is where the difficulty really starts. It means you can only see the arytenoids. You can see the back door to the larynx, but the vocal cords themselves are hidden.
And grade 3 is also subdivided.
Often, yes. Into thigh, where the epiglottis is visible and you can lift it, and I-IB, where it's stuck down or you can only see the tip. Grade 3 remains the same, no view.
So what's the clinical takeaway? How does this grading correlate with the likelihood of a difficult intubation?
This is the whole point of the system. If you get a grade or a grade 3 view, intubation should be straightforward.
But with IAB 3,
grades IB 3 are associated with a significantly higher incidence of failed intubation. That's a critical threshold.
And if you get a grade 3 view?
If you get a grade 3 view, you must abandon the attempt with that device. You immediately switch to an alternative plan, a bougie, a video laryngoscope, something different. The grade you achieve dictates your next move.
Just for a complete answer in the exam, what's the POGO scale?
The percentage of glottic opening, or POGO scale, is another system. It tries to be more objective by measuring the percentage of the vocal cords you can see, from front to back. It's not used as much in daily practice, but it's great for research because it's more reliable between different observers.
The need to overcome those grade 3 and 4 views is what really pushed the field into its next era, video laryngoscopy. Let's really dig into this technology.
VL is the direct technological solution to the anatomical problem of the direct line of sight.
Okay, so define it for us. What's the basic principle in simple terms?
A video laryngoscope is, at its heart, an indirect laryngoscope. It uses a tiny video camera chip embedded near the tip of the blade to capture an image of the glottis. That image is then sent to an external screen.
So you're not looking into the mouth anymore?
You're not. The core principle is that you are looking at a virtual image. This means we are no longer trapped by the need to align the patient's oral, pharyngeal, and laryngeal axes. We can effectively look around the corner of the anatomy.
And what are the components that make this possible?
You still have a handle and a blade, of course, but the key additions are the micro video chip camera that captures the image, the video system that transmits it, and the high-resolution LCD monitor that displays it. You watch the screen, not the patient.
Let's get into the different types of video laryngoscopes, starting with how you get the tube in.
This is a crucial distinction. First, you have channeled VLs like the Airtraq. They have an integrated guide tunnel built right into the device.
So it's a bit like a point and shoot.
In a way, yes. You get the glottis on screen, and then you just advance the ETT through the channel, and it guides it right where it needs to go. This can make it much easier for novices.
And the other type?
The other and more common type is non-channeled. This includes devices like the Glidescope and the CMAC. Here, the blade just gives you the view. You still need to use a separate stylet or a bougie to steer the tube into the trachea, using the screen for guidance.
The second classification is about the blade shape itself. Macintosh style versus the hyperangulated blades.
Right. The Macintosh-style blades, like a CMAC and Mac blade, are designed to mimic the curve of a standard Mac blade. This is great because you can use it for both direct laryngoscopy looking in the mouth and video laryngoscopy looking at the screen.
But the real game changer was the hyperangulated style.
Absolutely. The hyperangulated blades, like the classic Glidescope with its 60-degree curve or the CMAC D blade, are designed almost exclusively for indirect vision.
And their shape is their superpower.
It is. Their extreme curve allows them to provide a superb view of a very anterior larynx, that classic grade 3 view that a standard DL just can't get. But because of that shape, they require a very specific technique.
Let's talk about that, the working principle for these hyperangulated blades, specifically the need for a stylet.
This is a major exam point. The hyperangulation gives you this phenomenal view of the chords, but now the path from the mouth to the trachea is a sharp curve. You can't just push a straight tube and expect it to go in.
It'll just hit the back of the pharynx.
Exactly. To make the tube follow the curve of the blade and pass smoothly through the glottis, you must use a pre-shaped stylet.
A hockey stick shape.
The classic hockey stick shape. You bend the stylet to match the curve of the blade. Forgetting to use this stylet, or not shaping it correctly, is the #1 reason people struggle with VL, even when they have a perfect grade eye view on the screen.
Okay, let's list the clear advantages of VL over DL. This is a huge comparison point.
First and foremost, the quality of visualization. It's a large, bright, magnified, high-resolution image. It can turn a difficult grade 3 view into an easy grade 1.
And anatomically.
It bypasses the need for that perfect axis alignment. This is massive for patients with limited neck mobility.
And the impact on how we learn.
It's revolutionary for teaching and training. For the first time, the instructor, the trainee, the nurse, everyone in the room can see the same view of the glottis simultaneously.
So no more over-the-shoulder teaching.
Exactly. The instructor can give precise, real-time feedback. It's an incredible teaching tool. And from a safety perspective, you can keep the larynx in view the entire time you're placing the tube, which reduces the risk of some of those blind maneuvers.
Of course, we have to talk about the other side of the coin. The limitations and challenges of VL.
Right. They're not a silver bullet. They still require some degree of mouth opening, so a patient with severe trismus is still a major problem. They also don't have the same versatility as a flexible fiber optic scope.
You can't go through the nose.
Can't go through the nose, can't go through a tracheostomy, can't use them to check a double lumen tube's position, or for suctioning the lungs.
And what about the time factor?
This is a really important challenge. Getting the view is often very fast. But the time to intubation, the actual act of passing the tube, can be significantly longer, especially for people who aren't experienced with shaping and using the stylet.
And more time means more stress on the patient.
More apnea time and a greater hemodynamic stress response. Blood pressure and heart rate go up.
And finally, the camera itself is a point of failure.
A huge one. Vision obstruction. Secretions, blood, or even just the patient's breath fogging up the lens can render the device completely useless in an instant. This is why some devices have things like oxygen ports to blow the lens clear.
This brings us to the area where VL really proves its worth. The role of video laryngoscopy in the difficult airway.
This is its home turf. VLs are now considered indispensable, not just for the known or predicted difficult airway, but for the unexpected one you encounter at 3 a.m.
Why are they so good when you're anticipating a tough intubation?
Because they can give you that great glottic view, changing a grade 3 to a grade the first without needing all the force and tissue manipulation that DL requires. This is especially true in cases of an anterior larynx or a large tongue. They're so effective that they're now formally part of the ASA difficult airway algorithm.
And their role as a rescue device after a failed first attempt.
The clinical evidence is overwhelming. They are a fantastic rescue device after a failed DL attempt because they offer a fundamentally different mechanical approach. Channel devices like the Airtraq have even been shown to be superior to DL when used by novices, leading to faster, more reliable success.
Let's revisit this special case of cervical spine immobilization. This is a must-know.
In any trauma patient where you're holding manual inline stabilization or MILS, your goal is to minimize neck movement.
And DL causes neck movement.
It does. Even with MILS, the force needed to get a view with DL causes measurable displacement of the cervical spine.
But VL doesn't need that force.
Right. Because of its around-the-corner view, it requires minimal head or neck manipulation. Study after study shows that VL results in significantly less C-spine movement compared to DL in this scenario. This makes it the default choice for any patient with a potential C-spine injury.
And as you said, its role in teaching is transformative.
It just accelerates the learning curve so much. Instructors can see exactly what the trainee is doing and guide them precisely. Using a VL with a Macintosh-shaped blade is especially useful because you can teach the conventional technique and the video technique at the same time.
This is the perfect time to consolidate all this into that definitive comparison. Direct versus video laryngoscopy. Structuring this as a table in your mind is key for the exam.
Okay, let's hit the main points of differentiation.
First, visualization and line of sight.
DL relies completely on a direct line of sight. You have to align the three axes. VL uses indirect visualization through a camera, bypassing the need for axis alignment.
Next, the learning curve.
DL requires extensive hands-on practice to master the physical skill of alignment and lifting. VL, on the other hand, often gives novices a faster initial success rate because the view is so good, although mastering the stylet for tube insertion is a separate specific skill.
What about success rate in difficult airways?
DL is very successful in normal airways, but that success drops off a cliff with Cormack-Lehane grades the 3rd and 4. VL demonstrates a much better glottic view and therefore a higher success rate in those anticipated difficult airways.
Applications.
With DL, the big risk is dental trauma from levering and vagal stimulation. With VL, the risks are more about a prolonged intubation time, leading to more hemodynamic stress, and that unique problem of the view being obscured by fog or secretions.
Less than availability.
DL is cheap, it's everywhere, it's durable. VL has a much higher initial cost for the device and monitor, requires maintenance, and often uses expensive single-use blades, which adds up.
And to recap, for C-spine immobilization.
DL is associated with more C-spine motion. VL is strongly preferred because it's proven to cause less movement. And just a quick advance point for the exam double lumen tubes. Some studies suggest that even though VL gives a better view, the wide open space provided by a standard Macintosh blade might actually make it easier to railroad a big, bulky DLT in a normal airway. Better view doesn't always mean easier passage.
Okay, let's dedicate this next section to the critical complications and safety considerations that every anesthesiologist must have memorized.
Let's start with the big one again, dental trauma. This is the #1 reported mechanical complication of DL.
And it's almost always preventable.
It is. It happens when you misuse the teeth as a fulcrum instead of applying that clean, perpendicular lifting force. Curved blades are generally a bit safer in this regard than straight blades.
What about soft tissue injury, especially with VL?
While DL can cause injury during insertion, VL has its own specific risk. With those hyperangulated blades and the stiff pre-shaped stylet, if you're too aggressive, the rigid tip of the tube can cause trauma to the pharynx or the larynx as you're trying to railroad it through the cords.
And the ultimate failure, esophageal intubation.
It's a catastrophe we all work to avoid. This is one area where VL really shines. That continuous, magnified view of the glottis allows you to watch the tube pass through the cords, which significantly reduces the incidence of this complication.
Let's reiterate the management of laryngeal spasm. This is a true crisis.
It is. It's a reflex closure of the glottis, usually triggered by some kind of irritation under light anesthesia. For the exam, your management plan has to be clear and decisive. First, remove the irritant, deepen the anesthetic.
And if that doesn't work?
If the spasm is severe and doesn't break, the definitive answer is a rapid onset neuromuscular blocker. Acetylcholine is the classic choice.
What about physical maneuvers?
You should absolutely mention applying firm bilateral pressure at the laryngospasm notch, that little spot behind the jawbone. It's often very effective. And while we often use CPAP with 100% oxygen to try and force the airway open, you should be aware of the paradox. Sometimes that high pressure can actually worsen the spasm.
And revisiting the VL-specific problem of fogging and secretions.
It's the Achilles heel of the technology. Blood, secretions, or just warm, humid breath can blind the camera instantly. That's why features like an oxygen port on the blade to keep the lens clear are so important.
Okay, let's put it all together in a real-world context. Clinical decision-making. How do we choose the right device for the patient in front of us?
It's all about matching the tool to the specific task and the patient's anatomy.
So, for a routine, straightforward, normal airway.
DL is still the conventional standard choice for most practitioners. You'll default to a Macintosh size 3 or a Miller size 2. The choice between curved or straight often just comes down to personal preference and what you're most comfortable with.
But the moment you anticipate a difficult airway,
The standard of care shifts immediately. You should be reaching for an indirect device. That means having a video laryngoscope, a flexible scope, or an optical stylet ready to go. If you absolutely have to use DL, you should at least be using a modified blade like the McCoy.
and in the high-stress environment of an emergency airway.
The first attempt needs to be the best attempt. Visualization is everything. This is why VL is being integrated more and more into emergency algorithms. It maximizes your chance of getting a good view on that first critical look. And of course, having all your backup gear suction, a bougie, a smaller tube ready, is non-negotiable.
And one last time for cervical spine immobilization.
VL is the preferred technique. Specifically, the hyperangulated VLs like the Glidescope or CMAC. You choose it because it gives you the view you need while causing significantly less C-spine movement compared to DL with Mills. It's a clear choice for safety.
We've arrived at the purely exam-focused section. Common exam questions and Viva traps. The tips to maximize your score.
Okay, let's talk classic Viva questions. You will be asked to define laryngoscopy and to define a difficult airway using the precise ASA criteria.
Which are?
More than 3 attempts taking more than 10 minutes, or the need to use an alternative device or adjunct. You have to know that definition.
And the practical show-me questions.
They'll ask you to describe the mechanical difference between the Macintosh and Miller vallecula versus direct lift. And that big comparison of DL versus VL in a difficult airway will definitely come up. And be ready to instantly describe the features of a McCoy blade.
What are the common student mistakes that will cost them marks?
Number 1, without a doubt, is the fulcrum error. Do not say you lever against the teeth. Emphasize that the lifting vector is 45 degrees up and away. Secondly, the VL trap. For hyperangulated VLs, you must state that you need to use a pre-shaped hockey stick stylet. Forgetting that is a major clinical and exam failure.
And what are some of those examiner-approved safe answers that show you're a competent, safe practitioner?
Always mention using optimal external laryngeal manipulation or the BURP maneuver, and be clear that an assistant performs this to improve your view.
Good point.
For confirming tube placement, your gold standard is always capnography. Mention the clinical signs, but finish with capnography. And for managing severe laryngospasm, if simple things don't work, your safe, decisive answer is to prioritize giving a rapid onset muscle relaxant like acetylcholine.
This is great. Now for the written paper, diagrams and exam presentation. You've said that drawings are essential for a top score.
They are non-negotiable. They communicate so much, so quickly. For a 20-mark answer, you need to draw a laryngoscope with a blade and clearly label all the parts: handle, spatula, flange, tip, and the fiber optic light path.
And to show the mechanism.
You need 2 small, simple sagittal view diagrams, one showing the Macintosh tip in the vallecula for the indirect lift, and the other showing the Miller tip scooping under the epiglottis for the direct lift.
And the required anatomical drawing.
The Cormack-Lehane grading. You have to draw the 4 classic views, neatly labeling the vocal cords, the epiglottis, and showing the progression from a full view in grade 4 to no view in grade 4.
And for VL.
A simple schematic of a video laryngoscope show the angulated blade, the camera chip near the tip, and an arrow showing the image going to an external monitor. It perfectly illustrates the concept of indirect sight.
What are the specific labeling details that will really impress an examiner?
In your diagram of the lifting technique, draw an arrow and label the force vector as 45 degrees up and away. For your Cormack-Lehane drawing, specifically label the difference between grade tea, showing the posterior chords, and IIB, showing only the arytenoids. And for the sniffing position, label the two components, cervical flexion and atlanto-occipital extension.
Finally, how do you structure that big 20-mark answer to guarantee you hit all the points?
Use clear numbered headings that follow a logical progression, just like we've done today. Start with the history, define your terms, classify the devices, explain DL, then VL, then do a detailed comparison, and finish with clinical applications and complications.
And use the diagrams throughout.
Use your diagrams liberally, label them neatly, and make sure you include the modern stuff like VL and the McCoy blade. Conclude with a tight summary of the key clinical safety points.
That is a complete framework. Let's do a rapid-fire review in our final section, summary and exam conclusion.
Okay, here's the high-yield recap for instant recall. DL, especially the Macintosh, is the standard. It uses the vallecula for an indirect lift. VL offers indirect visualization, bypasses the need for axis alignment, and is superior in difficult airways and for teaching.
And the grading.
Cormack-Lehane rates IIB 3, informing you're in difficult territory.
Safety.
Safety is everything. Avoid dental trauma by using the correct 45-degree lifting vector. Severe laryngospasm is a true emergency that requires a rapid onset muscle relaxant if initial measures fail.
Okay, let's consolidate this into the 12 absolute must-know facts for your exam flashcards.
1. Laryngoscopy's goal is glottis visualization to aid intubation. 2. The history goes from Kirstein's DL in 1895 to Pacey's VL Glidescope in 2001. 3. DL needs the sniffing position. VL works without mandatory axis alignment. 4. Macintosh is curved using the vallecula. Miller is straight for a direct epiglottis lift. 5. The McCoy blade has an articulated tip to reduce force and dental risk. 6. CL grades IIB and 3 mark the start of significant intubation difficulty. 7. VLs are classified by channels, like Airtraq, or angulation, like Glidescope. 8. VL is preferred for C-spine immobilization because it reduces neck movement. 9. A key limitation of VL can be a longer time to actually pass the tube, increasing patient stress. 10. Dental trauma is the single most common mechanical complication of DL.
11 and 12.
11. Hyperangulated VLs require a pre-shaped hockey stick stylet to prevent mucosal trauma. And 12. The definitive gold standard for confirming ETT placement is always capnography.
That level of detail is fantastic. To put a bow on it, give us a model conclusion paragraph for that theory paper.
A strong conclusion would be something like, laryngoscopes remain the cornerstone of airway management, evolving from the direct line-of-sight technique of Macintosh and Miller to the advanced indirect visualization of video laryngoscopy. While DL remains the primary technique for routine cases, VL is indispensable in the difficult airway, offering improved glottic views and superior protection in cases of cervical spine instability. A proficient command of both systems, coupled with a deep understanding of laryngoscopic grading and anatomical risk factors, is crucial for safe and effective anesthetic practice.
Perfect. We've covered the entire journey, from the first rigid scopes to today's high-definition devices. To leave our listeners with a final thought, the difference in visualization quality that VL provides is just undeniable. It's like going from a pinhole camera to an HD screen.
It is, and that leads to the provocative question you should be thinking about. Given that VL offers a better view, better teaching, and a safer profile in trauma, we have to ask, are we rapidly approaching a point where video laryngoscopy will simply supersede direct laryngoscopy as the routine standard of care for all airways, regardless of predicted difficulty? If that's the case, then mastering these skills isn't just about passing your exams. It's about defining the standard of practice for your entire career. Good luck with your studies.